Thank you, Dr. Chitra and the entire team of Aios for having me here to speak on do all cases of intermediate uveitis need treatment and to speak against the topic. So thanks, Mudit, for your inputs. So when it comes to intermediate uveitis, it's not always very easy to label a case of uveitis as intermediate uveitis because of all the anatomical classifications. It is the anterior and the posterior uveitis which are most well-defined and hence most well-recognized in clinical practice. So intermediate uveitis does pose a challenge when it comes to diagnosis and treatment. And the problem is because we don't have standard guidelines for the treatment, we don't have an endpoint for treatment of intermediate uveitis, and there is no clear consensus on the threshold for treating versus not treating. So as Mudit has highlighted, the factors that we take into consideration are visual acuity, presence of vitreous cells, and the other features of intermediate uveitis like snowballs or snowbanking, presence of cells in the anterior chambers, cystoid macular edema, and traction components. If these are severely affected, of course, we treat, but when do we not treat? Now, let me show you an example of this woman in mid-40s who presented to us with bilateral complaint of bilateral floaters, blurred vision for almost 3 to 4 months. And you can see the vitreous haze, you can see vitreous membranes and significant vitritis to the point that right eye, the vitreous opacities did look like snowballs. So when we did the fluorescein, we found some peripheral vascular leakage in the right eye, and in the left eye, the disc was quite leaky. So do we label this as intermediate uveitis? We were on the point of labeling this as bilateral intermediate uveitis. Of course, there was no cystoid macular edema, which was very evident on the fluorescein. So we decided to have a look at her anterior segment, and the left eye showed IOL with some deposits on the IOL, and the right eye clinched the diagnosis. You can see the copper nodules and moth-eaten appearance of the iris. So this was actually a case of bilateral fuchs, which is not so common, but has significant vitreous involvement. And you may get carried away by treating this patient as intermediate uveitis. Another patient who presented with blurred vision, 624, 636 vision in the right and left eye, 6 months. You can see the fundus is not really visible. You can only see the optic disc. These are the optos images, significant vitritis. We tried to do the OCT to look for CME. We couldn't. We got very hazy scans and the lens was very clear. There was no cataract. Similarly, in the left eye, we didn't get any scan. What do? We assessed the anterior segment, and you can see the amount of the intensity of the vitreous membranes on the slit lamp examination in the right eye and the left eye. And then a closer look, repeat look at the cornea revealed single KP in each eye. The LFM was almost normal, 6 and 4 in the right and left eye. So there was no inflammation in the anterior segment except the KPs, but the vitreous was dense. So we got the fluorescein done. Again, we didn't have any information, but the clue was this was a 75-year-old male who presented to us. So we did a diagnostic vitrectomy straight away. We couldn't think of giving steroids. We didn't know actually what was going on. So we did a diagnostic vitrectomy in one eye, and we found that this was actually a case of primary vitreoretinal lymphoma, which was mimicking as intermediate uveitis, and the old records that the old man was carrying showed bilateral intermediate uveitis having been exposed to steroids. MRI did reveal involvement of the brain, and this was post-vitrectomy. You can see the media is absolutely clear. The retina is absolutely fine, no cystoid macular edema, similarly in the left eye. Now, this was a young boy, 21 years old, referred to us. He was already on oral steroids and azathioprine for 2 years with a diagnosis of right eye intermediate uveitis. Surprisingly, his media was quite hazy with vitreous membranes, and we found that this patient was nothing but a case of fuchs. And I've seen more and more patients with intermediate uveitis need to be screened first for ruling out some other etiology rather than ruling in to be them as intermediate uveitis. So the question is, why do we make mistakes? Why do we err? Because the threshold for treating every case is very low. We want to see every case and we want to treat. We want to do best for the patient. But in that attempt, we sometimes make mistakes. And because of the misconception that all cases of intermediate uveitis or intermediate uveitis like uveitis need to be treated, and especially sitting in a referral center, it's important to first rule in or rule out intermediate uveitis, because we are not going to have patients who present always at the stage of the first episode of intermediate uveitis where you have lot of cells in the vitreous, you have frank cystoid macular edema, you have snowballs hanging out there. So you may have these patients in intermittent or in the late stage. So the decision is to be taken when to treat them. And of course, as certain entities which may mimic and appear like intermediate uveitis, if it's a classical presentation of intermediate uveitis, it depends entirely upon the stage of activity. And I'll just quickly take you through this reference. It was a study in Germany where 159 patients of intermediate uveitis were retrospectively analyzed. And surprisingly, out of all the treatment that those patients got, there was almost one third, 22.5% of the patients who required no treatment. So there was a significant there was a significant subset of patients who did not require any treatment despite being intermediate uveitis. To summarize what we follow in our practice and what I would advise is, if you have very active inflammation, even if the patient is asymptomatic or minimally symptomatic, prefer to treat. The patient is symptomatic, but no inflammation or minimal inflammation. Minimal inflammation, that means the patient has had the active acute attack. It is a residual inflammation. Assess the cause of symptoms. If the symptoms are purely floaters, you can observe or just do a floaterectomy. If the symptom is decreased vision, we have to assess for the cataract because the patient has been exposed to steroids or any macular complications like an epiretinal membrane and go for vitrectomy. So these patients need to be assessed very carefully before we decide what case is to be treated. And I believe that there are a lot of patients of intermediate uveitis who would actually need no treatment. Thank you very much.
Thank you very much, Dr. Reema, and it was a great set of talks. I have a question for Dr. Avinash. We'll start with him. Now, since I'm still in a confusion that which asymptomatic cases need to be treated, because everything seems to be a little elusive here, but would this hold good that we treat asymptomatic cases in a pediatric age group, or how do we observe that particular age group?
I think, Chitra, you nailed it on the head about the pediatric case. But just before that, pun unintended, Mudit, I'd like to congratulate you again and again on successful ophthalmic practice in a busy HCD clinic. So, coming back to the point, Chitra, about pediatric cases, yes, that certainly falls into a realm of indication for treatment in these cases, in majority of them. So having answered that question, so the three important points which we would like to consider why this debate is all about, because we know that some of these which have no underlying etiology can spontaneously resolve. And there is also a thought process is we have to outweigh the risk and benefit of treatment with prolonged corticosteroids in few cases. And the third point is like what Reema had brought up, or the persistence like in fuchs cyclitis, where these patients tend to persist and there is no treatment required. So these are three important points for which we brought about this debate about the discussion. And Mudit had brought about a different paradigm in terms of bringing in the complication, which is also an indication for treatment, and an underlying etiology which should be looked at and should not be overlooked. Even if the patient presents with vitritis, these patients have to be investigated, and if found to be positive, has to be treated. And in this case, it happened to be syphilis. So those are the important points, I would say. And apart from the point what you had mentioned, pediatric age group is something which we cannot have these guidelines set for observations.
Dr. Srinivas, would you take the next question with Dr.
Yeah. So I just for the sake of PGs and the fellows who are participating here, so I just like to know, how do you differentiate between the fresh and the old vitritis and the vitreous cell? And my second question is, although MS is not a common condition, but what are the ophthalmological clinical clues to suspect multiple sclerosis in a case of intermediate uveitis?
This question is to me?
Yes, sir, JB sir.
Yeah. Actually, my examination starts from the slit lamp examination itself. So I look very carefully in the anterior vitreous cells, and I can make out that difference between that active or is inactive or old vitreous cells. Active vitreous cells are white, a little larger, and there are clumps can be seen, and the pigmented cells are, this is the old anterior vitreous cells. I don't treat that cases. And another important point is that before I forget, I don't treat the visual acuity. Even a 6/5 vision, I have treated the patients with immunosuppressive or posterior subtenon injection. The reason is that if I see vitreous cells, that is my parameter for treating the patients of intermediate uveitis. So another point to which Dr. Reema has told rightly, that we should not miss the vitreoretinal lymphoma. The reason is that they can be a serious life-threatening. This is a serious life-threatening disease. If a patient of 50 or more than that, if you see that vitreous opacity without snow banking, keep a possibility of vitreoretinal lymphoma. If they're not responding, you should go for a vitreous biopsy in such cases. I've seen even 30 years age patients also develop vitreoretinal lymphoma. So you need to be very careful about that.
Can I add a point?
Yes, Dr.
Yeah, actually, in cases where we are not able to make a decision whether to go for treatment or not, FFA helps us a lot. FFA, if you have vasculitis and the peripheral vascular, non-vascular, non-perfused areas, that shows that definitely we have to treat. So FFA has a very good say in intermediate uveitis.
So I find it's a little difficult to do FFA in children. I do an OCT, so to get an idea about that macula. I look in every intermediate uveitis patients carefully, the fovea, if the reflex is sharp. If there's any dull reflex, if it is seen, I just go for an OCT, because the way the patient loses the vision is a cystoid macular edema or ERM. That's the way intermediate uveitis patients lose vision, irreversible loss of vision.